This brief video will share information on gestational diabetes as part of the complex antepartum lecture. GDM is defined as hyperglycemia with onset or first recognized during a pregnancy, and this is from the Canadian Diabetes Association's 2018 guidelines. Patients with GDM have increased risk of developing glucose intolerance later in life, as well as type 2 diabetes later in life. There is an increased risk of adverse maternal and fetal outcomes when we have patients who have poorly controlled glucose levels. So even a mild GDM can cause an increased risk for perinatal mortality morbidity. When we think about diabetes in pregnancy, it's very similar in terms of the mechanisms that happen and the pathophysiology. But if you do need a review, the Khan Academy video that I posted in the PowerPoint is a great one. You can start at around 2 minutes and 20 seconds. I'm not going to test you on the specifics of patho, of course, but it's helpful to know what's happening and when you think about applying that to your patient care. So screening for gestational diabetes, there's two different kind of methods that we use, and it should be done within, which I'm going to tell you about in a few minutes. Universal screening should be done within 24 to 28 weeks. And if someone has risk factors, we screen earlier. So the interventions are very similar to, the regular adult population. We want to have good blood glucose control. We want to promote that healthy diet. We may be referring these people to a diabetes educator if they have access to that. Exercise, monitoring blood glucose levels. We don't order things like or administer things like metformin during pregnancy. So often diet, and then if patients need insulin, if things progress, then we'll move to that. Fetal health surveillance is very important because, again, there are increased risk factors, which I'm going to tell you about in a few minutes. When we think about the physiological changes of pregnancy, this does impact insulin requirements. So that's why we see gestational diabetes manifesting during pregnancy or diabetes manifesting during pregnancy, which makes it gestational. First of all, fetal nutrient demands rise during the late second and third trimester. We talked about this in the regular antepartum class about nutrition, how caloric intake is increased in that second and third trimester to account for these increased fetal nutrient demands that are needed. Insulin requirements also begin to rise during that second trimester, so there's more glucose use, more storage, and use of glucose increases. Placental hormones, so HPL production and growth hormone in particular, also are increasing because we have this placenta, this growing fetus, and this can cause an increased resistance to insulin. Most people are able to increase their insulin production to compensate for this resistance. However, if the pancreas isn't functioning properly and it's not able to produce sufficient insulin, or if the insulin isn't used effectively in the body, then we end up with gestational diabetes. Remember that the glucose crosses the placental barrier. The fetus actually then increases insulin production. And this is why in these babies postpartum, they end up with hypoglycemia. And I'm going to tell you a little bit more about that. However, like I said, if you do need a review, please do watch the Khan Academy video. It's really helpful. When looking at signs and symptoms, you're going to see similar to what would be in a non-pregnant patient: polyuria, polydipsia, polyphagia. Weight loss can happen as well sometimes, so you'll want to be assessing for that, assessing blood glucose level, assessing for ketones in urine. All of those things will still be the same. When we look at what's happening with the baby, so again, with the picture here, you can see that the high blood glucose level in the mother actually brings extra glucose to the baby. And so what happens is then the baby does cause the baby to put on extra weight. So we end up with that macrosomia. However, if the blood glucose level is high in the mom, then the baby's going to produce more insulin. And so they're taking in more glucose. At birth, what happens though is that cord is cut, the supply of glucose is cut off, but babies still have this really high level of insulin circulating. And then suddenly we end up with low glucose or hypoglycemia. So it's normal to have a normal low after birth because this blood glucose supply from the mother is not there. But in a gestational diabetic patient or someone with gestational diabetes, you'll actually see that they'll have that increased hypoglycemia. So this is something to consider for these babies. Any patient, whether they have gestational diabetes that is controlled by insulin, by diet, or any glucose intolerance, will be doing blood glucose checks on these newborns. Some of the gestational diabetes complications in the mom, which I mentioned, there is increased morbidity mortality. They end up with polyhydramnios, extra fluid. Gestational hypertension can happen. You may see some of those things like retinopathy that are occurring, especially if glucose is poorly controlled. You may see hyperglycemia leading to ketoacidosis, increased cesarean birth because of those bigger babies. UTI, of course, they're at risk for infections, including yeast infections, and retinopathy, which I just mentioned. In terms of problems of the newborn, again, this is because of the increased maternal plasma glucose levels. There may be more congenital anomalies, and so they may be at more risk for anomalies of the heart, central nervous system, and skeletal system as well. Macrosomia, that's that excessive birth weight, so they're bigger babies. There may also be intrauterine growth restriction if it's really severe. Sometimes I would see IUGR more with type 1 diabetic patients. And respiratory distress can happen as well because what's happening is there's actually an inhibiting of fetal enzymes that are needed for surfactant production. And so these babies don't have enough surfactant. Polycythemia, because the excessive red blood cells, hyperbilirubinemia, which is that immature liver that's unable to metabolize increased bilirubin because of the polycythemia. These babies are bigger, so they may have shoulder dystocia and other birth injury. And I already talked about the fact that these babies may have neonatal hypoglycemia at birth. So there is my giant baby Sam, macrosomic baby, and I was glucose intolerant for sure. I probably would have had gestational diabetes based on the current guidelines now. So he was 10 pounds and 9 ounces. So big, big baby. Making the diagnosis is really important. We want to make sure that everyone is screened at 24 to 28 weeks gestation. And if there's a high risk of GDM, then we want to offer screening earlier on in pregnancy. When we look at this screening, this is from CDA. They're between 24 and 28 weeks. We do a glucose tolerance test or challenge test. And so we have them drink a special drink and or take some kind of glucose. And then we wait for an hour and we check the glucose after that. If it's normal, then we're good to go. If it's not normal, and you can see the values on there, if it's less than 7.8, then we may reassess if they're tested earlier or they continue on with their pregnancy and we monitor all the things that we're usually monitoring. If it's between 7.8 and 11, then we're going to move on to a 75-gram oral glucose tolerance test where they drink something or consume that glucose, and then we check their blood values later. If one or more value is met on that one, you can see the diagnosis of gestational diabetes is made. If they do this 1-hour test and they're greater than 11.1, then they go right to a diagnosis of gestational diabetes. There is an alternative approach as well, and you can see this is a 75-gram right away. And this may be in situations where like they're not accessing care, they're not able to do the assessment for a variety of reasons, so we go right to that 75-gram. When we're looking at maternal surveillance for GDM, as I mentioned, you're checking for ketones. You are also going to be checking for protein, nitrates, and leukocytes. There may be kidney function evaluation because again, there may be kidney disease, changes to the vasculature as well. So creatinine and protein, BUN as well, eye exam, and checking those hemoglobin A1C levels. And just letting people know that if they do have gestational diabetes, that they are more at risk later. It's the same with preeclampsia, which we're going to talk about next. Patients with preeclampsia or hypertension during pregnancy are at increased risk for cardiac disease later in life. So our goal, of course, is to maintain euglycemia during pregnancy and labor and birth to reduce the risk of complications. And we've already talked about what those interventions are. During the intrapartum period, we want to keep those blood glucose levels at less than 8 millimoles per liter. And if we have that really tight control during intrapartum, it does decrease the risk or severity of newborn hypoglycemia. Postpartum, most people return to normal glucose levels after birth, and we've already talked about the risks later in life. So for the baby, we want to be assessing fetal well-being. We want to make sure that baby's growing well and just doing that very close fetal health surveillance as well. So let's just do a little practice question here. A nurse is teaching a client who's 28 weeks gestation and has GDM how to control their blood glucose levels. Diet therapy alone has been unsuccessful, so they've started insulin. Which of the following should the nurse consider effective when the client says, which of the following? Sorry, that wording is not great. So which of this, you can select all that apply. So which of these tells you that your teaching's effective? Is it, if my diet's good, I can skip my insulin? B, I'll monitor my blood glucose levels twice a week. C, I need to use insulin every day. D, I need to monitor my blood glucose levels regularly and adjust my diet and insulin as needed. E, I can eat as many carbs as I want as long as I take my insulin on time. So select all that apply. So I need to take my insulin every day is correct and need to monitor blood glucose levels regularly as well. So of course, we don't want people skipping insulin, carbohydrates, that's a misconception. It's really important that we provide teaching on that. And symptom-based monitoring isn't something that we would do, of course, so we want to make sure that people know to monitor frequently and just making sure that we're empowering the patients and families that we're working with so they have the knowledge and skills that they need to manage the condition. Hopefully that information is helpful. We will come back to hypoglycemia in the newborn in the high-risk newborn class. Thank you.